Hello everyone, a very good evening to all, and my name is Dikshant Gangawat, and today I will discuss about the Integrated Child Development Service Scheme. And for this I have referred one quote that is from the Nelson Mandela's book, and here I will read that first. All children are our future, and one of the basic responsibilities is to take care of them in the best and most compassionate manner possible. So, like, there's a very famous quote for the Mr. Gandhi also, and in that, if you want to know the progress and growth rate of the any nation, then you don't need to go through the statistic, but simply study the position and status of the woman and the child care there. So this is very famous quotes by the very famous personalities. So today I will discuss this scheme, and in this scheme I want to give the brief. Like, first we will study who are the beneficiary of this scheme, when this scheme was introduced, the historical aspects of this scheme, and third thing I will discuss about the what are the how this scheme is helping in the Indian society, and also the scheme's way forward, challenges, and how we can deal with that. So all the things I will discuss in the brief. So first of all, guys, so let me start with the scheme. So see, Integrated Child Development Scheme is world's largest community-based program. So across the globe, if we see this scheme, so it's a very big scheme, and that was introduced in 1975 by the Congress government, but there was some issues at that time. So mainly that issues was like 1978 when Morarji Desai's government came, so they stopped this scheme. I'm not sure about the whole reasons why they stopped this scheme, but the thing is that, like, the scheme's main objective was on three factors. One was the nutritional aspect, second was the health, and third was the education. So let me brief about all the factors one by one. So first I will tell you who are the beneficiary of this scheme. So scheme was targeted mainly for the 0 to 6 years of age of children and the pregnant and lactating mother and woman, and in the age group of 16 to 44 years. So the scheme's three factors that I told you was the health, nutrition, and education of the target community. So to improve that one, they launched this scheme on the 2nd of October 1975, and the operational age, if we talk about for this scheme, is all about the 30 to 35 years something. So majority of children, if we see the position in the Indian society, it's not very good, if we say, because as per the study in 2019 data statistics, then we see that 28 deaths per 1000 live births, means under first age birth. So like, what is the infant mortality? So first I will define what is the infant mortality. So death of young children under the age of 1, that is the infant mortality. So that is the data, that 28 deaths per 1000 live births, that is this data. So see, this is not a very small data, because just because of one problem only, the 28 deaths are happening in 1000 live births. Okay, and if we take the under 5 mortality rate, that is bigger than this, like that is a 34, and 25% of the newborn children are suffering from the nutritional problems, and they are underweight. So, but some variations are there that I will teach later in this lecture only. In the urban and rural areas, there are different variations for the underweight and the overweight obesity. Okay, so first let me tell you the historical aspect of this scheme. That ICDS was the scheme that was launched in the 1975, and the scheme was in accordance with the national policy for the children. Okay, over the years it has grown into the one of the largest integrated family and community welfare in the world. There are many schemes in the world, like Brazil. If we talk about the Brazilian health infrastructure, so this is not a infrastructure like India, but you know, if we compare this scheme with the other countries' schemes, this was the biggest scheme for the child welfare and the pregnant women and lactating mothers welfare. So here we talk about the certain factors for this scheme was that the following services are sponsored under the ICDS to achieve the objective. So there are 6 factors in this scheme. First was the immunization, and second was the supplementary nutrition that I have already discussed, and health checkup. Fourth is the referral services. Fifth is the preschool education or non-formal, and sixth is the nutritional and health information. So it was all about the child care and in the age group of 0 to 6 years of age. So if nutritional aspects first, that is the biggest aspect of this scheme. First I will tell you about the nutritional aspect. So here see concentrate here, that is the beneficiary children. So children who are age of 0 to 6, and in the male child if we particularly talk about that, so 500 calories are defined by the WHO, that is minimum requirement there, and in 500 calories the protein quantity should be 12 to 15 grams. And if we talk about the girl child between the 0 to 6 years of age, their calories is needed more as per the biological factors, and also the protein quantity is also needed more. So if we talk about the calories should be the 800 calories, and the protein quantity should be 20 to 25 gram. So these are the some standards that is already defined by the WHO. So what was the main, if we focus on the main objective of this scheme was to reduce the infant mortality. Infant mortality I have already told you. Now next thing is the morbidity. If we talk about the morbidity, what is the morbidity? So morbidity is defined by how frequent a disease can occur. So that is the morbidity. And to reduce the infant mortality, morbidity, and the undernutrition problem for the child care, this scheme was the first. This scheme was launched, and the second was to lay the proper foundation for the proper psychological and physical and social development of the child. So this was the second objective. To see, if we think about the only physical development only, that is not the one aspect of the health, because the mental problem is also there, and many syndromes are occurring just because of undernutrition problem. Now we will see what are the 6 factors here. So first I have told you that to improve the nutritional health status of the children in the age group of 0 to 6 years of age. Second was, I have already told you, to deal with the psychological and the physical and social development of child to reduce the incident of mortality, morbidity, malnutrition, and the school dropouts. In India, if you study, school dropout rate is very high. Okay, so there are many problems here. Fourth was to achieve the effective coordination of policy and implementation amongst the various departments to promote the child development. Fifth was to enhance the capability of the mother to look after the normal health and nutrition need of the child through proper nutrition and the health nutrition. So what was the thing here? The education is not all about the books, because here comes the role of the nutritional education. The parent should know how much nutrition is needed for the child in between the age group, as per the age group. So it should be known by the parents. So this scheme was launched to make awareness about the nutritional health also, and for that government opened some Anganwadi centers, and there were many sub schemes of this scheme like Anganwadi services, and one scheme was a scheme for the adolescent girls. So Anganwadi services, if we talk about the Anganwadi services, so like in the urban areas there are 1.83 lakhs of Anganwadi, and in the rural areas there are 13 lakhs something Anganwadis. So it's very big picture for this scheme, like 13 lakh. Can you imagine that 13 lakhs Anganwadi? So that's the way that's the reason we are saying that this scheme is the biggest community development scheme. So now we will talk about the expenditure factors of this scheme. So like earlier, what was the thing? Like it was a centrally oriented scheme only earlier, but what was the thing? What was the thing? The expenditure of this scheme was only handled by the state by state. So like, see, there are many lots of problem in the states also. So we only states funding is not sufficient for this type of biggest community development scheme. So here comes the picture after center authorized that expenditure, and now the center and states are sharing 50-50 ratio for this scheme's expenditure, and there are many fundings from the world's most organizations like the WHO also, and the World Banks also, they are also supporting for this scheme. And the way, if we see this scheme right now, it's doing very well, but there are some challenges that we need to deal with it. So now next, if we take the things, now we will talk about the some challenges and way forward. Okay, so the first challenge was the reduction in the proportion of undernourished children in India over the past decade has been modest and slower than what has been achieved in the other countries. Problem is that India is also the developing economy, and there are other countries are also there for the developing economies. The problem is that in those countries, this type of schemes are performing better, and here just because of some few problems, this scheme is not working well. Okay, so this is the first challenge, okay, that we had in front of our society. Second was like, while aggregate levels of undernutrition are shockingly high, the picture is further. If we see the outlook of the states and socio-economic groups, then girls, rural areas, and the poorest and the scheduled tribes and the caste are the worst affected, and these inequalities appears to be increasing just because of the inequalities in the society, and just because of the caste system, and just because of the poorest and the poor areas. So this scheme is not implementing very well on the grassroots level. So that is the second challenge for us. Third was the child malnutrition is the mostly result of high level of exposure to the infection. So just see, if some child is in undernutritional phase and he is suffering from any syndrome, so there is a more chances of the infection. Okay, so this one describes like that only. So inappropriate infant and young child feeding and caring practices, and has its origin almost entirely during the first 2 to 3 years of life. The problem is in first 2 to 3 years of life, but this scheme is working after 4 to 6 years of age. So that is the problem. So next point, if we take about it, ICDS. The ICDS program, while successful in many ways, has not made a significant dent in child malnutrition, and this is the mostly due to the priority that the program has placed on the food supplementation, targeting mostly the age group between 4 to 6 that I have already told you. But here the focus should be on the 0 to 3 years of age, because once the 0 to 3 years of the age passes, just and with the undernutritional conditions, then we can't change after 4 to 6 years of ages these factors. Okay, so these are some challenges in front of us that we need to deal with it. Now I will discuss about some of the points. By adopting these points, we can, like, in future we can plan better for this scheme, and we can reduce the challenges here also. The first is the ICDS program should be directed towards the younger children. First focus should be in the 0 to 3 years of age group, and most vulnerable population segments in those states where the undernutritional rate is very high. So first focus on those states where the undernutritional rate is very higher, and then we will move towards that regions that are less suffering from this problem. So like that. Second is that ICDS program should aim at the improving the mother's feeding and caring behavior. We have to provide the nutritional education for the mothers also. Like in Anganwadis, we have to increase the productivity and enhance the capacity for that. And third thing is that, like, improving the household water and sanitation. Sanitation is very big problem, for this one, because just because of that many infections happen, and the child suffers from the different types of diseases just because of the undernutritional problem occur. So that is the thing. third thing is that strengthening the referral to the health system with emphasis on the prevention and the control of common child diseases and including the acute malnutrition. Fourth thing is provided micronutrients, and the fifth thing is the urgent changes are need to be bridges the gap between the policy intentions of the ICDS and its actual implementation. So if we talk about this scheme on the grassroots level, so recently I have met with some persons who are already working in the health sector, and I asked about this scheme. Literally they was saying like this scheme is not doing very well right now. Just I asked what are the factors like where we are lagging in the implementation of this scheme. So they have added few points. So these points were like the Anganwadi centers are not working very effectively, and there are many Anganwadi centers in the rural areas. And one more thing like that came out of the conclusion, that was like the problem in the urban areas and the problem in the rural areas for the undernutrition, that is different, and we are following with the same approach. So that is the problem. In the urban areas, the problem is obesity. Their problem is not the underweight, their problem is the overweight. And in the rural areas, their problem is the underweight. And we are going with the same concepts. So how the same concept will work with the two different variations? That's why the government came up with the concept of the revamping of this scheme. So there, government is thinking about that we should start the two different approaches for the urban and the rural, and separately for that. So this is the very good point that came out of the conclusion, the discussion. Okay, and this last thing is that additional consideration I will discuss. One was the nutrition indicators. So see, the demographic and socio-economic patterns at the state level don't necessarily mirror those of the national level. So see, if we study, it's like that, like if you are studying for different state and their conditions are different. But if you are talking about some different state, like if you talk about the northeastern states and if you talk about the southern states, so their conditions are not matching, and there are various factors that depends on the undernutritional values, and also like there are also environmental factors. Okay, so we should study state by state data statistics, and we should not rely on the national level data. That is the first thing. Second thing is that undernutrition is concentrated in relatively small number of districts and villages, suggesting that the future efforts to combat the malnutrition could be targeted to the relatively small number of districts and villages. So for this is the second thing. And third thing is that the micronutrients deficiencies are widespread in India, especially among the preschool children, and the progress in reducing the prevalence has been very slow. So this is also the one of the nutritional mismatch, we will say. So third thing is that the program mismatch. The key constraints on the ICDS effectiveness is that actual implementation deviates from the original design. So what was the original design? To reduce the infant mortality. And what was the age group? 0 to 6 years of age. But I told you earlier that it was working mainly for the age group of the 4 to 6 years of age group. But here there was no consultation and there was not a good child care for the 0 to 3 years of age, and they were ignoring totally for this age group. And this is the problem, because the problem is that the actual implementation deviates from the original design with the increased emphasis on the provision of supplementary feeding. Okay, so that was the thing. So what was the result of this scenario? Like the most children under 3 years don't get the micronutrient supplements, and the most of their parents are not reached with the counseling on the better feeding and the child care practices. So this is the problem, because see the economic conditions if we see of the Indian society, that is also not good. But we should if this type of schemes are coming, if we better implement this scheme in a general way, like taking the exit data for the state, exit data for the region. So we will be able to implement this scheme very effectively. Okay. So second point is this, that children from the wealthier household participate much more than the poorer ones, and the ICDS is only partially succeeding in preferentially targeting girls and lower caste who are at the high risk of undernutrition. So this is the second thing. So although program growth was greater in underserved than the well-served areas during the 1990s, that time it was like going very well. See, if we talk about although the program growth was greater in underserved than the well-served areas during the 1990s, the poorest states and those with the highest level of undernutrition still have the lowest level of program funding and coverage by the ICDS activities. So their funding is more required, their resources are more required. There it is very less, and there it's an imbalance between the healthcare infrastructure. We can directly say that. Okay, and the next thing is, if we discuss about that is the program operational challenges. So see, this type of big scheme that is for the very big community, because India is the second most populous country in the world. Okay, so see, the inadequate worker skills. So what the mean by inadequate worker skills? That is like the nutritional education of the skills of the worker, okay, who are working in the Anganwadi centers, and they are not very well skilled for the health informations. They are not very well known for the nutritional aspects of the child. What are the required for this age group, and like what are the benefits for the pregnant women, what they should take in the intake during the pregnancy, and what should be the nutritional value or nutritional range for the different child age group, and how they should deal with it. Okay, that is the one thing. And second thing is the medical checkups. If we talk about that, they are also not having the specific ideas, specific skills for that also. So there is a lack of skills and the shortage of equipments and the poor supervision and the weak monitoring and the evaluation. So this is the second problem. Okay, and the community workers are overburdened because they are managing two things. One thing is that the food supplementation. Food supplementation is for the 4 to 6 years of age group. Okay, and the education till the 0 to 6 years of age group. So that is the overburden, because we need the more skilled workers. That is the one thing. Okay. Second thing is the program recommendations. The program recommendation is that if we talk about that, supplementary feeding activities needs to be better targeted towards those who need it, with a clear criteria set for admission, quality assurance and accountability. So see, if we talk about the region specific, where this scheme is more required, where the undernutritional average data statistic is more than the national level. So if we see in 2019 study, the statistic was 28 deaths under the age of 1 on the 1000 live births. So there are some region specific. It's not the same for all the areas. So that region specific is that there are more than 28 deaths on 1000 live births. Okay, so this is the thing. Second is that the growth monitoring activities needs to be performed with a greater regularities, with an emphasis on using this process to help the parents understand how to improve their children's health and nutrition. There should be nutritional education to the everyone. Every parent should know how much nutrition is required for their child, whether it's in the rural areas, whether it's in the urban areas. So they should know in the exit factors what are the requirements, how we can care for the better early childhood education and for other resources. Okay. So second thing is that involving communities in the implementation and the monitoring of ICDS can be used to mobilize additional resources, the Anganwadi centers, okay, and improve quality of services and delivery and the increase accountability in the system. Okay, so accountability is the main thing, like how well this scheme is working, how the resources are working, how much effectively Anganwadi centers are working. If we talk about in our childhood example, if we take about that, okay, so if we take that example, during the polio vaccination, literally I saw some of the problems that are on the grassroots level, and one of the problem was they are literally, this is not a duty they are taking as a duty. This is not a duty for them. This is like one day they will come, okay, their main thing is that who want to take that polio vaccination, they will give, otherwise they will not focus on every house. That is the biggest problem, because their duty should be, they should reach out every house. That's their responsibility. Okay, because people are not so much educated in the rural areas, and they are not caring about the early childhood education, early childhood health, and the nutritional aspects. So that is the Anganwadi centers. The problem is the Anganwadi centers, the productivity and the capability to reach out every house and to make the awareness about all the factors. Okay, so that is the biggest problem. Second thing is that monitoring and evaluation activities and need strengthening through the collection of timely, relevant, accessible, high quality information to the decision, and improve performance quality and increase accountability. So that I have already told you. Okay. Second, if see in the real scenarios for this scheme, I discussed with many health workers. Okay, I just now I met with some health workers and some doctors also. I discussed with this scheme. So there are 1.83 Anganwadi centers in the urban areas, and in the rural areas that is 30 lakh something. But still the implementation is not perfect. So what is the problem? Problem is the funding. They told that funding comes from various departments. Okay, funding comes from the WHO, funding comes from the World Bank also. Okay, but the funding is not reaching out. The reason is specific. Where there is a requirement, there is no funding. Where there is less requirement, there is funding, there is the resources. That is the imbalance of health infrastructure. So that is the thing. Like, that is the imbalance of health infrastructure in the India. So that's why, and the many problems like the inequalities, we talk about the inequalities, untouchabilities. So these factors dominate in the society over these schemes. So without removing, without combating with these types of things, how well we can implement this scheme? That is the problem. That is the main grassroots level study for this scheme. Whatever we read, that doesn't matter, that is implementing very well. For implementation part, we need to look for the ground issues. So these are the outlooks. Okay. So that's it for this scheme, and thank you. Jai Hind. I hope that the better child care development and the women's care and the pregnant and lactating mothers care will lead to a young future healthy generation, and also the very educated generation that can be self-independent, that can play a role in the society development, and the whole country will be happy if a child and women that are healthy and which are like if they feel very healthy and very good in the society in terms of the status, in terms of the health, in terms of the education. So whole society will lead towards the development if their position of the woman and position of the child is very good. Okay. So that's it for today. Thank you. Jai Hind again. That one point I wanted to add. That's why I again added this point. Thank you. Thank you so much.